So it's 7:29. I think in the interests of being prompt, I think we'll get started. My mic on, John? A few minutes. Yeah, that's great. Thank you. So it's this is the second of our leadership rounds, which we're going to have quarterly. And this morning, delighted to have Dr. Doreen here this morning with us. As you probably remember, a couple of months ago, we had a first of our rounds, and Doreen was gracious enough to agree to come and tell us about her leadership journey. Doreen's one of those leaders that flies a little bit below the radar. She doesn't tell a lot of people about what she's done, but she's done an amazing amount of things in her career and supported our specialty and our profession, and our patients ultimately, in ways that most people don't know about. But she'll probably tell you a little bit about that on her leadership journey. Before I ask Doreen to take over, and we'll have some questions and discussion at the end as well, or maybe even during the presentation. The next round is going to be on June 6th. I've actually managed to get Dr. Andy Smith, who's our CEO and president, to come and talk to us about his leadership journey and about where he sees healthcare going in Ontario in the next number of years, and more as important as anything, what our place is going to be in that system and how we can lead in that system. So I'm looking forward to Andy's presentation as well. So with that, Doreen, thank you so much for coming to present to us. I know you were probably throwing together these slides in BC while you were skiing last week. You're probably cursing me at the same time, saying, why the hell did I agree to do this? But thank you so much for putting this together anyway. Doreen.
Hey, Colin, thank you for the invite. Yes, I was actually, BC is like early. I was just thinking about it in BC, and it's been done in the last week. Anyways, I'm impressed all these people came to listen to this. So I titled this my inadvertent leadership journey, because it's nothing like I set out to do. So I have to say that when I finished my residency at Queen's University, did a fellowship at St. Michael's in QI and clinical outcomes. And towards the middle of that year, my sister said to me, well, do you have a job yet? I said, well, actually, I haven't started looking. So she gave me the gears and said, get off your butt and do something and start looking. So the next thing I knew, I kind of ended up here. But my real goal after my whole fellowship was to go to teach anesthesia in a developing country, which I ultimately did get to. But again, none of this was planned. And so here are the objectives for today's talk, which I believe were circulated. So like the start, like any of you who think after you get your exams, you want a job. You want it in a place you can work, where you like the work, where you like the people. I think that's what most of us actually are after when we finish. We don't think, okay, I'm going to go in there and be a leader. So again, as a junior staff, you kind of think, well, I don't really have much to contribute. I don't know anything. I'm just new here. And I hear that from a lot of junior staff. And I'm going to say, well, you know what? That's not true. Like, give yourself some more credit. So I think the first thing to do when you start out as a junior staff is you need to establish yourself clinically as a solid anesthesia consultant. You want to make your opinion count. You want to be heard. You want people to believe you. And, there's certain ways to go about doing that. And sometimes it can be challenging navigating this part. I just find, so first of all, as a visible minority female that wasn't very tall, you kind of have to do something. And I think we all have our little things that we have to, I used to think, well, those tall white guys, they're going to believe them. They're not going to believe me. So I felt like I had to do something more. And part of it was that you need to be assertive in a nice way about what you do know, but also be humble about what you don't know. So being assertive does not mean being arrogant. It just means being assertive. And be humble about what you don't know. It's not shameful to ask for advice or ask your colleague or ask for things that you don't know. And why is this important as a medical leader? Because I found over the years that if you want to be a medical leader that leads other healthcare workers, the first thing you have to be is credible as a clinical person, okay? So if you're a bad clinician, right off the bat, you set yourself in they say, well, that person doesn't even know what they're doing in their specialty. how can we possibly believe them in any kind of leadership or management position? So that's really important amongst people who are medical. Now, crazy enough, lay people and min people don't know the difference because, to be fair to them, they don't see you practice medicine or anything. So they just see the MD behind your name and they figured, yeah, that person knows everything because they're an MD. We all know that's not true, right? But sometimes the admin people, lay people don't realize that just because you're a doctor. So part of it, it's one of my favorite pictures. So these are our retired and senior leaders within the Department of Anesthesia. I believe one of them is in on the Zoom.
Yes.
Yeah, Gil's in on the Zoom. He's the one on the your far right. And Dr. Byrick on your far left is retired. And unfortunately, Kirk Weber, who the Weber Lecture is named after, has passed, but he was who was chief of the department when I was recruited. So I think they gave us a lot of great role models and examples. And you might say, like, why would I bother to go into any kind of leadership position? Why don't I just go in and do my clinical work, keep my head down, you know, take care of patients and go home? Well, you actually have more knowledge than just doing clinical care. Okay, your knowledge gives you the ability to make patient care better. It allows you to make teams work better. And also, if you're really, really good, you can drive innovation and various other improvements that other people may not have thought of. So give yourself more credit. You know a lot, and you know beyond what just patient care needs. So the first thing I'm going to admit right here is that this slide was partially made by AI. Okay, full disclosure, because I was playing with a program, and it gave me all that fancy language that you see on the right in the smaller print. But the bottom line is a lot of fancy, fluffy language. And the last line in the bottom is kind of summarizes the whole thing. Why should you lead is because you want to improve patient care in your work environment, and all the other stuff is fluff. Here's another partial AI slide, but I provided the content. So I think you need to believe that all of us have the ability to lead in some way, small, medium, or large. And even though you're a new person, leadership is not about hierarchy. Okay, junior people will know stuff, the senior people don't. And I think when you come on, you need to remember that. Just because you're the new person, it doesn't mean you don't know special things. And I think that the thing that maybe new people forget is that us older people have been in a system for a long time. When you come and join, you bring new perspectives from your experiences. You bring what I call fresh eyes to a department, and they actually look to you for input. So please, wherever you go, remember that. For example, our residents have the advantage of rotating through, you know, a bunch of different hospitals. So those of us who've been here for a while, we don't see what happens in different hospitals. You can bring that perspective to us. The work environment for our specialties, it's unique in a sense that it didn't really dawn on me till maybe like a decade in, that we work in a large group, we work in teams. Unlike a lot of other physicians who may just be in private practice, they go to an office. I hear about some of my colleague ladies in my choir who are, say, rheumatologists and stuff. They sometimes just see patients on Zoom. That's it, one-on-one in their little office. They Zoom with a patient. That's their clinical environment. Ours, well, there's like dozens of people around every day. Think of all the people you meet on a daily basis through your workday. And just remember, everybody is kind of watching you, like how you behave, how you treat patients, how you interact with allied health, how you interact with the floor cleaners. Everybody knows what you're like because people are watching every day. So again, just remember that, because that's how people form impressions of you. You know, if you misbehave in that environment, they'll remember that. If you behave very well, they'll remember that too. And I think that's part of building your credibility as a consultant and a leader. We have all that opportunity to do that. We also have the opportunity to mess it up if we don't if we don't do that part well. So we have that unique environment for working in teams. And the last one, I think I've already talked about. Oh, and some of us have had previous careers, and even with your previous career that was not maybe involved in medicine or anesthesia, you still bring a perspective that others may not have. I don't want to use Devin as an example because he's laughing, but Devin has, you know, special computer science and other skills and engineering that most of us don't have. Other people have, you know, other careers in the past. This is just the AI slide with a lot of fluffy talk. So I think I said in my goal that I was going to bring some personal examples from my career and some of the examples from junior years. And again, this is an inadvertent journey. I just joined Sunnybrook 30 plus years ago. Dr. Weber recruited me, and I came on in one of my first calls in the OR. They were doing 24-hour call at that time. And I came in the morning on a call day. I worked straight through 24 hours. And the next morning, kind of like come out of the OR, like it was 8:15. Nobody had come to my room. I looked out in the hallway. Everybody had started their room. And I thought, you know, if this is the kind of places, I can't work here. If this is what my first calls will be like every day, every time I have first call, I'm going to have to leave because I can't do this. And I thought, I need to change this. I really need to change this. So I brought it up at a meeting. Well, you can imagine all these senior male members of the department, like, oh, new people, they just can't take it. And of course, at that point, it was like, these women, they can't take it either. Like, it's just like, wow, we've been doing this for years. The usual things that you hear. So I thought, you know, this might not go anywhere, but I got to keep trying, right? So it took about a year before they thought, well, you know, we could try it, I guess, for 6 months. And, you know, it's going to decrease your income because you have to hire more people to cover the shorter first call. So all the usual excuses. Okay, after the 6-month trial, it wasn't even brought up again. They just kept going with a decreased call. So that's, I think that was one of the earliest recollections I have of, you know, how you can change stuff. It takes time. You'll get poo-pooed at the beginning. Not always, but frequently. Other things I started doing, again, to try to improve the clinical work environment was, in those days, there was no coordinator. But to be fair, the OR was not nearly as busy as we are now. But basically, everyone went to the room, did their thing, and went home. And then first call came and took the latest room. You could be stuck, but you also had the option of canceling your room if you didn't feel like doing it. So that was a crazy thought, is that I remember, I'll never forget, one of the members of the department had a flight to catch. So at 2 o'clock, they decided, you know, I think I'll just cancel the last case, but nobody knew, right? Nobody knew. Like that person took off and everyone else is in their room doing their thing until someone heard, oh yeah, so such and such got canceled. And I said, what do you mean? And I thought, again, that's not right. How can this happen? So I instituted the coordinator role. I instituted the daily activity sheet that we're still using now, I think, where you get to see where everyone is. We instituted a relief list. The number of calls started going up. Like there used to be first call and sort of a second call, and then it became third call. And well, you know how many calls you have now. So again, all these things took a long time, but they got done. So the lessons here, changes can be quite slow. And it takes a bit of persistence and patience to keep at it. So again, here is what I feel are the criteria needed if you want to be a leader. So clinical competence, we already talked about that. You have to be a clinically credible person. It's sort of like a brand extension, you know, like so-and-so's good clinically, so therefore, you know, maybe their leadership ideas are also credible. You need to be familiar with the work patterns. So I think most of us have seen people come in and try to change our work who know nothing about the OR. So I think a good example was when we had the Ernst & Young consultants come in. Everyone's nodding their head. They came and told us our OR efficiencies were terrible. And here's this guy who's like an MBA guy in a suit, who looks like he's early 30s, telling me my OR was inefficient. I mean, I had a few words and thoughts about that, and I think as most of us did. So you need to be familiar with a work pattern if you want to change things or lead it, okay? And if you're not familiar with the section, you need to ask, because you can't just go in there and sort of, change things when you don't know what's going on. Honesty and transparency, again, it's really important. People, if you're a leader and you're not honest, or one time you renege on something, everyone's going to remember you for that forever, okay? That one time. So I think it's important. They tend to remember the negative things, not all the good things you've done, but, oh, they lied once, or they didn't follow through, or whatever. So I think that's really important. Effective communication. And that's probably one of the hardest ones, communicating with people, because people communicate here and then people listen down here, or the other way around. Verbal communication, written communication. But I find over the years that half the time when people with communication is listening. Like, I think that's such an important component, is that people, when they come to you, they want you to be listening, and not the kind of listening where you're just impatiently waiting for them to finish so you can say your bit. Like, truly listening to them, reacting to what they say, and trying to understand their perspective about where they're coming from. And all this, trust building. So trust building doesn't happen overnight, doesn't even happen in a week or a month. It happens over many months and years that people trust you. So if you want to be a leader, these are the things that you could try to achieve. So here's another example of a leadership position I was sort of put into. It was a challenging time for Sunnybrook, because in the late 1990s, early 2000, we were forced to amalgamate with Women's College Hospital. And a lot of people who were around remember those times. It was a crazy, tumultuous time. Some commission decided that it would be best if women's joined Sunnybrook. So if you look at the backgrounds of each hospital, you realize they're like diametrically opposed. Women's College evolved because women could not get training positions in Toronto. So Women's College Hospital was rah-rah women. There was like some radical women on the board that were quite staunch feminists. It was all about women and their rights and all this stuff. Sunnybrook, however, evolved as a veterans hospital. Well, you could see, like, never the twain shall meet. So when we were forced to merge, there was a lot of chaos. And the hospitals had no choice. We had to form a first amalgamated medical dental staff. And someone from Sunnybrook thought, oh, gee, let's put Doreen as like the president of the medical dental staff, because hopefully she'll like bring them all together, because she's female and she's from Sunnybrook. She's on our side. And so I was put in this position. And I thought, okay, let's be honest, I didn't really know what I was doing. You just sort of stand up there, smile a lot, listen to people, and nod your head and saying, yeah, I really understand, whatever. The year and a half went by and people said, you did a great job. And I thought, I don't think I did anything, but to be totally fair, but I was present. I smiled at people and I listened to them. Okay, that's what it was. And I had some ideas about what should be done. But like, I was getting it from both sides, from the Women's College people about what should be done, and from the Sunnybrook people about not letting the women take over. It was just on and on crazy. So again, that was interesting experience. And then after, like, I don't know, 2, 3, 4 years, this whole shotgun marriage was like stopped, and we demerged. We divorced and we kept the kids. That's the way I look at it. Because that's what happened. We got obstetrics. We never had obstetrics before because it was always at women's. And when we amalgamated, we somehow kept the kids. And initially, like many of these sort of things, there was no room to house the kids. So the kids were still down at Women's College for quite a while. And it was a Sunnybrook floor at women's, and there was a women's floor. It was crazy. but it's sort of like, you know, the guy sleeping in the basement sort of thing. But anyways, so that was an interesting leadership experience. I have no idea what I accomplished, but somehow it kind of went. My third example of leadership, it was a tough time for me. It was shortly after the women's merger had happened, and it caused a lot of things for Sunnybrook. A lot of the male leaders in our hospital left because of that merger. They saw no future for them because like the women's were taken over. And a lot of these people that were groomed to be leaders sort of saw the writing on the wall and said, you know, we're out of here. And we left. So we, unfortunately, Sunnybrook lost a lot of good leaders during that time, including our chief. So we searched for a new chief. We found a new chief. There's lots of hope with this new chief. I knew this person because we were residents together. At that time, I was the acting chief until he came. And after that, I was site chief for the Sunnybrook because we had now merged and there was Holland Center and women's 3 campuses, etc. The new chief, however, didn't do well. Okay, it was one of those things that people, you know, did great on the interview, like CV was right when he came here. It was kind of a mess. And you know, I was kind of like friends with him because we knew each other, and I was seen as being associated with him. So when he finally, quote, fell, guess what? They said, you know, well, you're with him, so you're out. You're out too. So I remember coming back from a 2-week holiday, and they say, you know, really, you should step down. And I said, what? Like, what did I do? What happened? And over those 2 weeks, things had happened with the new chief that were all negative. He finally did end up leaving. And I found myself, okay, I guess I'm not doing this anymore. So it was a bit of a shock and a surprise. And at the time, like you can imagine, I was pretty upset. I'd spent like 10 years doing a lot of things for this department. But again, these things happen when you're in leadership positions. And I think we've all seen examples of, you know, CEOs that are let go for whatever reason. In leadership position, this kind of thing happens. It has nothing to do with your clinical competence, but for whatever reason, other people see it as a time for a change. And it doesn't mean you did anything wrong, but that's the way it goes. So when all this happened, I thought, okay, this is time to do something else, time to pivot. Try not to take it personally, which is challenging because all these people were my colleagues and friends who now said, you know what, we think you should, you know, get out of this position. So I had to kind of pivot and just focus on something else. So I did. I went half-time to sort of separate myself from the department a bit more so that it wasn't kind of like ingrained in a place. And at that time, I was actually the treasurer on the Ontario Anesthesiologists. And I'd been doing that, really enjoyed doing that. It was it's a provincial organization that advocates for our specialty. And it also fights for fees, fights for OHIP fees, which as we know is very important. And during my reign as there, we had an excellent leadership team. Our anesthesia fees increased significantly during that time. The ASA codes, the triple time units, it was our executive that got all of that stuff in. Kevin Smith is a pain doctor. He was instrumental in pushing all these. And over this period, anesthesia, the specialty, saw their income. We used to be in the lower third of all specialties in the OMA. We sort of rose up to the kind of the lower end of the upper third. So we made great strides in terms of the fee stuff. I was kind of proud of that, even though I wasn't directly, you know, responsible, but I contributed. I managed to increase our section's wealth to $1 million. And when I started, it was 150,000 in the piggy bank. And by the time I left, it was about $1 million. So again, what do you do with all this money? I got the section to agree to sponsoring the CAS Residence Research Award. That $10,000 comes from the Ontario Anesthesiologists and has for the last 10 years. And the other thing that it was actually my idea, I said we need to invest in leadership for anesthesiologists in Ontario. there was a few instances in the early 90s that made me say that, because in those days, in the early 90s when I started, leadership was not a thing in our specialty. We saw examples of all sorts of departments that were kind of very disorganized. In fact, there was one hospital in the GTA that had their department taken over leadership by a surgeon. And I thought that was terrible. I mean, yeah, you probably remember, but their organization, Credit Valley, that their department was so disorganized about fighting over this and that, that the hospital finally said, you know what, we can't deal with this anymore. We're going to parachute a surgeon in to, take your leadership. And that example made me think, because I thought, okay, that shouldn't be happening. I find it very embarrassing that that's happening, and we need to do something about it. And so that's when we got the idea of investing the $1 million that we had raised into leadership initiatives. And we started off with that. And I believe it continues to this day. So that's something I did sort of focus more on when I had to pivot away. Took on some other roles as well. It's funny how you're in one or two roles and you become more visible, and then suddenly people come to you and say, hey, you want to do this? And then you realize you have to pick and choose what you want to do, because it can get a little bit too much. But Dr. Byrick, who you saw in one of the earlier photos, came to me and said, they're looking for a secretary for the CAS. They need somebody who's local to sort of manage the office and, sit on the executive and the board. And I said, yeah, sure, I'll give that a go. But at the same time, I was doing my MBA, so it was busy, but I was only 50% clinical here. So to me, it was a way of just sort of separating myself from what had happened to the department and being, let go of but just focusing on other areas in specialty that I could help out or advocate for. So got involved in the CAS that way, went to the board meetings. And the CAS, I encourage everyone to get involved in any or some of these organizations, because they allow you to get a sort of a view of what's going on in the country, in the province, so that you're not just like kind of mired in your own little hospital department and hospital and you don't know anything else. You know what's going on in the rest of the country. I feel that's important. So on the CAS, you get to influence all sorts of things. I remember being around the table when we were talking about the role of AAs that made it into the guidelines of practice. Every year you get to review the new guidelines of practice that come out from the Guidelines and Standards Committee and approve them, discuss them, and decide whether it's good for the specialty. And when I got involved in all this stuff, I thought, I'm not really trained to do any of this. Like, there's certainly anesthesia residency in medical school didn't train you to do any of this. So I think that had something to do with saying, maybe I need more training, and let's go get another degree or something like that. So that's what happened. The other thing I found was really interesting was at that time, the Ministry of Health had actually a good health minister for that government, and he decided there was a huge surgical wait list. No different than now, but this is before the pandemic. So he decided that the healthcare environment should form these perioperative coaching teams that would go around, visit other hospitals, and try to help each other increase OR efficiency. The idea being that maybe this could make a bit of a dent in the surgical wait list. So I joined one of these perioperative coaching teams, and I did that for a couple of years. And that was a load of fun. So the teams would have a physician, could be a surgeon or an anesthesiologist, and 2 or 3 nurse managers, OR nurses. And the team would go visit hospitals and learn about their whole perioperative program, their surgical processes, and then give input on how they could possibly improve. But, you realize when you do these things, it's a two-way street, because you learn from these other places that you go to as well, and you could bring stuff home. But they were looking to us as the experts. And of course, amongst the team, there would be people from 3 or 4 different hospitals. So everyone had different things they could contribute. I found that quite an enriching experience, just to see what goes on in like Hawkesbury, the small hospital in Hawkesbury, or the small hospital up in Kenora, how they do things. I remember telling the general surgeon in Kenora, I said, most of our lap colis are going home the same day now. And he goes, wow, I keep mine in for 2 days with a drain. I'm thinking, okay, well, I'm not a surgeon, I can't change you, but I said, you know, like, if you want to talk to one of our surgeons, you know, like, you can see how they do it. But, you know, there's a lot of places that are stuck in what they do and they never change because no one comes in and says, hey, you know, we're like the rest of the world's doing something different now. So, and one of our my more recent involvements with this department is being the rep on Pharmacy and Therapeutics Committee, which again, it's a role that I enjoyed, even though a lot of people say, well, you know, you gotta sit through and see what's going on with everybody else. But I think through my tenure on that, I managed to get Sugamidex on the cart. And not every place has that. There's a bit of a fight for that one because of the cost, but I think it's gone generic now. Is it cheaper now and everyone's using it like water? Okay. So when it first came out, it was $200 a vial. And it initially started as locked up in the drug cupboard. And so what I went to the P&T committee, I said, well, we can't have that because if we have a can intubate, can ventilate situation, you want one of our nurses to leave the room and go to the locked cupboard and sign it out. I said, that's not good for patient safety. So they all kind of grumbled a bit and said, okay, you can have Sugamidex in the cart. And I also got us IV Tylenol, which again, maybe not every hospital has, but I mean, hopefully the cost will come. The pain people are liking that. Again, it was a cost issue, and it took a lot of convincing at the committee because the internist sat there and said, well, Tylenol's useless anyways, it doesn't work. And I thought, well, like internists, you know, they're all into their evidence base and there's no evidence, et cetera, et cetera. And so we got it, again, in the OR for limited use, but I knew that as soon as we got it in on formulary in the OR, that the limited use would quickly become unlimited in a matter of a year or so. So I think that's what's probably happened. So that's some of the examples of the roles I was involved in. Here's some of our leaders. So the ladies decided to get together and make dumplings one year at Jane Wang's house. So we had a load of fun. But so I was going to say to you that we have, because of the kind of work we do in our work environment, we have lots of potential for leadership roles in very many different areas. Like, pick what you want. It could be within the department. It could be within hospital committees. Like, you can do your own department. You can do outside the department within the hospital, which I think is important because, again, we need to be visible outside the OR. Otherwise, no other specialty or allied health who's not in the OR will appreciate our specialty. If you don't leave the OR and show yourself, they don't know what we do. I mean, people don't understand what we do to begin with. But at least if you go out of the OR and, you know, make yourself known, that's a start. So participation in hospital committees, engagement with the university departments. We are an academic center, so we have an opportunity to do that. And one of my final roles was being fellowship director for the university for probably too many years. But anyways, that was an interesting job that our previous chair came and asked me to do, along with Dr. Trish Houston, they said, well, you know, it's difficult to find somebody for this because we don't want that person to piss off every department because it has to do with money. And they said, well, you've got an MBA, you should be able to figure that out. Maybe, I don't know about that, but I managed to do the role without ticking off too many of the departments. Because at that time, the fellowships were just kind of Wild West. Everybody was doing their own thing. Every hospital was doing their own thing. There was no sort of, you know, guidelines about what you can do. So kind of brought all of that under wraps. So that was a chance to engage with the university. And then involvement with provincial organizations, national organizations, even world organizations. So the World Organization, I want to make a pitch out there. The World Congress of Anesthesiology happens every 4 years, and the Summer Olympics, same year. If there's a Summer Olympics, there's a World Congress somewhere in the world. And the next one is in Vancouver. It's in Canada. So I want to see a lot of you out there, okay, being involved with that, presenting at that. I believe Dr. Hilary Grocott, one of the current chair of UBC, previous editor is the person in charge, the Canadian person in charge of dealing. And I want to see people in our department out there presenting, etc. And then again, involvement in things like the regulatory bodies. A number of us in the room, like Jordan, involved with the Royal College. Some people are involved with the College of Physicians, the CPSO. I became a out of hospital premises inspector, again, from the anesthesia part, so that you go into, say, endoscopy clinics and make sure that the anesthesia sedation practices are, you know, up to standard and so forth. So lots of opportunity for you to get involved in something that you like. That's an AI slide, so it's fluffy. I'm going to skip it. So we talked about that. So I actually want some feedback from all of you. This is a photo of the CAS Research Award winners in 2010. The final thing is I was also chair of the Canadian Anesthesia Research Foundation after my CAS role. But that's fundraising for research funds for anesthesia research across the country. So it's a picture of all the winners. And that year I was very proud because everybody was from U of T. So you may recognize some of these people. It was a Toronto suite that year for the awards. And I continue to be involved with that. But Stuart McCluskey is now the chair of CARF. As you know, he's a staff at TGH. I kind of pass that on to him. So these are I think we talked about this. Okay, so leadership style. Look what you got. I'm not sure why Howard did that, but got nice legs. What was the occasion? I don't know. There's something going on. This is not meant to be a big discussion on leadership styles, okay? This is not meant to be a big discussion on styles because that's a whole other talk unto itself. But it's just to give you an idea of what the different kind of leadership styles in healthcare. There's authoritative, participative, delegative, transformational, and servant. And the servant one is a whole big category. There's big discussions on that, but something that maybe we could discuss at a future talk or something like that. The authoritative one is interesting because I realized that during my tenure as a trauma team leader, I think that was the style. You had to be authoritative. It wasn't like, you know, what do you think about this? It was like, do that. So I think that the key is that everyone probably gravitates to one of these styles, okay, whether you know it or not. But also realize that different situations will require different styles and that one style does not work for everything because you'll be bound to either come up with, be faced with resistance if you're authoritative all the time because your peers will not, you know, accept you being authoritative all the time. But if you wait for participative, sometimes things just don't get done because you're just waiting too long for people to agree or whatever, right? Democracy is slow. But so I think you just have to tailor your leadership style to whatever situation you're trying to lead. Vern Nake is one of our past residents and now the current CEO of the Medical Council of Canada, right? So Vern's really quite funny, but I've got some of these things from him because he posts all these things on LinkedIn. But he's been giving a lot of talks on, you know, leadership and styles and coaching and so forth. And this came from another website, but it's an example, at least in the corporate world, of different kinds of leadership and which people emulate that. So you may or may not like some of these people, but nevertheless, they are leaders within their own right. And so, yeah, it was interesting. I just thought it was neat the way they had it related to different people. So if you can't see, the first one's the Visionary Leadership by Elon Musk. Bureaucratic Leadership from Indra Nooyi, who was the CEO of Pepsi, I believe. She was one of the top female CEOs in the world. Pace-setting leadership from Steve Jobs. Commanding leadership from Angela Merkel. Servant Leadership by Mahatma Gandhi. Charismatic Leadership from Martin Luther King. Democratic Leadership from Nelson Mandela. Coaching Leadership from Oprah Winfrey. And finally, Delegative Leadership from Jeff Bezos. Not that I know anything about how he leads, but that was the example given. Is there anything else? Yes. So I think we talked about this. So yeah, my own style, I guess it just depends on the situation. I talked about what in the trauma room, and ideally participative with peers, but the participative sometimes just takes too long. So you try to influence people by sort of talking to them in the background, saying, what do you think about this? And I think this, and eventually you may get enough people on board to agree with you that you've achieved your goal. But and the fun thing about this is that you can sometimes get people to agree with you without them realizing that they're actually agreeing with you. That's the most fun because you've somehow subliminally, influenced them. And then finally with the fellows, I thought there was a lot of coaching going on with fellows, because fellows are at a stage in the career where they just need a little bit of a push and maybe some advice about careers and, jobs and things like that. So again, you can change your style, your leadership style. So here are my take-home points. Just to reiterate, strong medical leadership requires one to be a solid clinician first. And the thing leaders sometimes forget is that a leader, because of all the different things you've been exposed to, your perspective is different from the people you're trying to lead. And I think people forget that. You're seeing more things than the people that you're trying to lead. So you somehow have to bring them up to your level by narrowing this gap, because the initial thing is they don't agree with you because their perspective is very different. And sometimes it's because you need to adopt some things from their perspective as well, because they see things different than you. So if you can sort of narrow that gap, then you'll be more successful. Listening. So communication, but I still think listening is like more than 50% communication. So you have to look like you're actively listening to someone when they come to you. I think that's really important. And the final thing is be passionate about what you're leading. Because there's nothing like someone who says, well, I was assigned to do this, but I don't really believe in it. But, that's not going to work. No one's going to follow you if that's your attitude. You need to really believe in what you're leading. So those are my take-home points.
Doreen, that was fantastic. I learned something new about your leadership every time I hear you. So thank you again for this wonderful presentation and for all of your hard work over the years. I don't see any questions in the chat yet. Do we have any questions in the audience? Carol, thank you.
So it takes up some of your time now. But it sounds like you went half-time and then your reach extended to different places. Was there a way to recoup some of your income? Like for those of us who are primary breadwinners for family before, to step away from the operating room 50% of your time to eat things, just an idea of where you can make money, where you're
So you're probably going to lose a bit of money because we know clinical work pays the most. However, some of the other roles do pay, but certainly not at the clinical level that we're paid at. And that's because the section got us all that money, right? So we're paid well. I think what's important to remember, so the college physicians does pay some stuff. The CAS pays your travel and sometimes your day. There's a daily rate for participating in the board or so forth. But you're right, this money is nowhere near, say, working on a Saturday night at midnight. That's not going to compare. I think you need to choose and pick what you want. And if you are the primary breadwinner, you won't be able to be involved as much, but choose one thing, two things that you really believe in. And the department does remunerate some admin time for some things. So, the pharmacy committee, I didn't lose income for going to that, but certainly for some other things, yes, you do it on your own time. And a lot of us do things on their own time anyways, including a lot of research people and other admin people, education people. So to me, that's sort of part and parcel of believing in something you do and advancing our specialty, that it's going to take some volunteer time. But I agree, if you're the primary breadwinner, maybe less.
Can I add to that?
Chance. Yeah, sure.
I mean, I think that's very well said, Doreen, but I think you're a little bit of an extreme example, and not many people go 50% to do what, and that's amazing that you did that.
But I needed to get away from the department too.
No, that's fair. Yeah.
Ulterior motive too. I mean, that's.
I mean, what I would say is I'm also the primary breadwinner for our family. I've got 3 children. I was fortunate enough to start off at Toronto Western Hospital with a great mentor, Vincent Chan, in 2000. And like Sunnybrook and like a number of other academic centers across the city, they remunerate some non-clinical time. But there's also a lot of non-clinical time that you do on your own time. And I would say it was probably 5% of my time a year in all reality. But many of us go to conferences, we present at conferences and things like that, and we do it on our own time. I suppose my point is it's an investment in yourself, because I've had a number of colleagues over the years, both when I was working in Ottawa and working here as well, that say, Colin, that mid-career period, I just really focused on making the money. And now I'm last stage of my career, and I wish I'd invested a little bit more in the things I'm really passionate about, which is patient care, advancing patient care, and all of those things. And it doesn't take much actually to invest in that. So that's what I would say. Just take a little bit of time and invest in it. Invest in the things you're really passionate about. I know that everybody in this room is really passionate about caring for patients and putting the right care in front of our patients. So it doesn't take a lot, and that, for me, that gets me out of bed in the morning. I'm sure it was the same for Doreen as well.
Question.
Mhm.
So, and I don't recall, you don't tell me what age this happened. When you had that, you got axed.
Mm-hmm.
So how did you navigate that? Can I ask, you said you separated, you had a distance. How did you navigate? Were you with people around you, colleagues? How did you, because that's a big emotional tax.
Mm-hmm.
To think that because you've risen, your trajectory is all positive. You're saying yes to everything and delivering, and they say no.
Yeah. So I went through a phase when I was just really angry, and said, that's it, not doing anything else more for this department. Boom, I'm moving to other things. Like, I'm going to move to national organizations or whatever. And that was the initial thing. And I thought, I need to spend less time here too. I entertained thoughts about leaving and looking at other jobs. And I thought, the reality is I kind of still like this workplace. So you don't want to shoot yourself in the foot just to whatever. So I thought, okay, I'm going to ride this out by being here less and focusing on something else. And for a long time, I didn't do anything for the department. I was going to sit in the background and let the new leadership take over, because I also did not want to interfere, because it was like, okay, I'm axed. I have all my colleagues telling me, we don't want you anymore. And I said, fine, you're not going to get me. That's it. So there was a bit of that reaction as well. And I moved on and, met other people in these other organizations, and, just looked ahead. I mean, it took a while. It didn't happen overnight. But that's.
Well, I applaud you, because a lot of us in our journey have faced imposter syndrome, whether as new faculty and even senior faculty. And I'm thinking about how somebody can lift themselves by the bootstraps and maintain your self-esteem to step back, because you continue to basically rock it with the things you did after you left.
Yeah, and I could look back and say I might not have done all those things if I had continued on doing stuff for the department and staying within the hospital sphere, right? So, in retrospect, it worked out, whatever. But yeah, there was a few, it was a tough year there.
Sorry, I'm sorry about it.
No, go ahead. I'll go after.
gonna ask a question about, I mean, opportunities. You seem to have had a number of opportunities, but did you have any opportunities that you didn't take and you regret now, or?
Yes. And do I remember what they were? That may not be that easy. I'm sure I did turn some things down because I thought, yeah, I'm not really interested, not passionate in that. And, you know, people say, well, you have no idea what you're getting into. And when you really look at it, how many of us really know what we're getting into? And if you never did anything, unless you knew exactly what you were getting into, you could never do anything, right? So yes, there's a bit of risk taking in all of these endeavors. Yes, you might fail. Yeah, that can happen. So, but you're right. I mean, I don't think we truly really know what we're getting into when we take things on.
Doreen, we've got a question from Yakobo on the chat here, which has been here for a few minutes. I'm just going to jump the line a little bit. Sorry, Beth. So he's asking, for those starting in similar roles now, what advice would you give them?
Similar roles in leadership?
Yeah,
you mean?
yeah.
To stay passionate, and don't be disheartened by initial lack of progress, because it takes time. Like it's like that first call change thing. It took like almost 2 years, and I didn't leave in the meantime because, you know, my next first calls weren't as bad. So stay focused and give it a fair trial of time before, if things aren't really going well, then before giving up, or ask for advice during this, you know, during this term. You know, what would you do? This is the situation I'm being faced with. It's not getting anywhere. You know, ask for advice from people more experienced than you. But stay passionate about the cause, because I think that's key.
Thanks, Doreen. Beth?
So, Doreen, thank you for all you do for this department, for our profession, for our patients. It's really been a privilege to work with you and also be your friend. I've watched your leadership over the years, and I think of two scenarios that always come to mind, and that's one, seeing you in the trauma room. And I used to love going down, and there'd be usual chaos, and there'd be Doreen, just calm, calling the shots. There's not a lot of kumbaya in the trauma room.
Authoritative.
You gotta do what you gotta do. But I watched your leadership style in that environment. It was always calm, steady, respectful. And even last year, watching that same style as you insisted that we host an international alumni event for our fellows in Singapore. Same thing. The idea comes up, you were persistent, you drove it, and then you hosted it. And you've always had that consistent leadership style that's just carried you through your career. My question for you is, at this stage, as you look back, what are the big surprises that you see and you've learned as a senior leader at this stage in your career?
So I was always surprised that, oh, people are actually listening to me. That's amazing. Must have done something right. So there's a bit of that, and that things can work out in seemingly chaotic situations, and that's certainly from the trauma room, that experience. But that's a clinical experience. It's very different than, you know, administrative leadership. But and people step up that you didn't expect. Like, just, you know, you said something and people come up to you and say, you know what, I really agree with you on this point, and, you know, I want to help you do this. And there's been some surprises there as well about who steps up and, you know, actually agrees with you. So positive things. Yeah.
Well, it's 8:20. Any final questions before we? Just want to say thank you again, Doreen. That was amazing. What I will do, sorry. What I will do is I'll ask Doreen if she'll give permission to get a copy of her slides, a PDF copy, and I'm actually going to create a Dropbox for leadership resources, and I'll put our previous presentations in as well, open to all staff, and I'm going to try and open it for our residents and fellows as they come through as well. But Dev, go on.
I suggest you ask Jonathan and host it with him.
It's a great idea. It's a great idea, actually. Yeah, Jonathan's probably the man to do that. Yeah, yeah.
I'll be using it.
Yeah, yeah. So thank you again, Doreen.
Okay.
It's fantastic.
Thank you for listening.
Very
Awesome. I've got like about 20 questions. Yeah.
Oh, I found here.
Stop yourself.
To for like 5 more hours. I'm
Stop.
It's so nice. Caring, and you're very interested in people's experience. Yes, that's another
Yes,
thing.
yeah.
So,
And I like stories.
I
So
know you do, you're great.
I like stories.
Thank you so much.
Thank you.